Okay, good afternoon, colleagues. Thank you for this opportunity to share our experiences as Durban on fast track cities. And I think Titus gave a very good background of where we come from with the fast track cities. Just to give a short background, Durban is now we call it eThekwini Metropolitan Area or eThekwini City. It is based in KwaZulu-Natal, which is one of the 9 provinces in South Africa. And KwaZulu-Natal has the highest HIV prevalence rate, sitting at about 18%. And eThekwini is the economic hub in the province, and it attracts quite a number of people that are flooding or influxing into the city in search for jobs and other businesses that they are doing. The picture that you see there, just a portion of the Durban showing the harbor. It's the largest harbor in Africa, so it's a very busy area which has got many people that are coming in mobile and others that are coming in to seek jobs. Just to look into the population, eThekwini has got more than 3.7 million people who are living in it. Of the 11 districts, it is the only metro, and it houses about 1/3 of the population of KwaZulu-Natal. We have an HIV prevalence of 17.6, where versus our national prevalence rate of 13.1, and you can see that that is a high HIV disease burden, and we have 53.5% HIV prevalence rates up amongst the sex workers. There is an estimated number of 52,000 people that are living with HIV. So we are responding to a very high or large number of people that are already HIV infected. Our epidemic then, the main mode of transmission is mainly heterosexual, and then we have a generalized HIV epidemic, though we are seeing an increase in key populations that are now coming out of the closet. So we don't know, we still have to go through that route and know exactly where we stand as the city. Also, the adolescent girls and young women are the ones that are mostly at risk and mostly affected by HIV. There are trends that have been observed where there is evidence that our young adolescent girls and young women are engaging in intergenerational sex, mainly for transactional purposes, where not as where they receive cash per se, but all these other things that they require, the weave, the expensive cell phones and everything. So they enter into intergenerational sex with the older men who have power, financial power to provide all those things, and yet they don't have much power to negotiate safer sex in those relationships. We also have a high TB and HIV co-infection rates, which forces us not only to respond to TB, but we are integrating TB and HIV. The most high-risk groups are the adolescent and young women, high-risk populations and high HIV prevalence in informal settlements, migrant workers, key populations, and community residential units, as we have quite many. And if you look closely at that map, it's just zooming into the areas where there is high HIV prevalence. Most of them are townships as well as informal settlements. We've got large informal settlements around the top ring there, which is, we call it the Ink, which is Inanda, KwaMashu, Tuzuma, and Phoenix, as well as lower down there at the south of the map, where it's also large townships like such as Umlazi and the other large informal settlements. So the city's response, how are we responding? When our mayor signed the Paris Declaration in December 2014, they found us already responding to HIV and AIDS. We were already doing a lot of work because I think of all the provinces, we had to do more because that is where HIV lives, if you like, in KwaZulu-Natal. So when the Fast Track Cities initiative was signed, it sort of helped us to focus and be able to monitor ourselves better to say what is it that we are doing. So our response then is multi-sectoral response where all sectors are involved through various structures. We have what we call Provincial AIDS Council, where the premier of the province is the one that chairs those meetings, and the mayors who are chair the district AIDS councils, they account to the premier to say what is it that is happening in each of the districts or the municipalities that they are leading. And at a municipal level, we also go down to a level of a ward, which is the lowest unit. And there we have the ward councillors who are actually chairing those ward AIDS councils. And they see to it that every sector that is available in that ward is participating, because that is where they discuss HIV, TB, and other social structural related issues that are affecting the response and the spread of HIV. That is where they discuss all those things at that unit level and put in interventions. So all the sectors have got targets, or they've got HIV and AIDS units that have got specific targets and specific interventions that they need to carry out so that everybody is participating. We have partnerships with the donor-funded organizations who are actually assisting us to actually go further with our interventions with the resources that they bring in. One of them being the PEPFAR-funded non-governmental organizations, and we also have UNAIDS and IAPEC who are also supporting us in terms of the Fast Track Cities initiative. And also we are also assisted by the policy framework that we have in the city goals, which we are working on, and all the energy we are focusing towards achieving those targets. Just to share with the eThekwini HIV 1990 cascade for HIV, or maybe before I get here, when the 1990 or Fast Track Cities initiative was introduced in 2014, in 2015, the National Department of Health, Minister Motsoaledi then adopted the 1990 Fast Track Cities initiative, but they extended it to also include, they added the 1994 TB. So we have a TB cascade and an HIV cascade, because as I have indicated, we have got a very high HIV TB co-infection rate. Therefore, our response would not be complete without tackling the two at the same time. So looking now at our HIV 1990 cascade, we have that total that are living with HIV above 652,000, almost 653,000 people, which are living with HIV. Of those, 91% already know their status because they have been tested. So we've got 90%, our first night was sitting at 91%, but we still have to do even more, because the 9% that is not accounted there, they are going out there and something is happening, spreading the virus. And of those, we have got 77%, which is the total, who are already on ART, on antiretroviral therapy. We are having a bit of a challenge because there are competing options out there. As much as we have ARVs, but our people, most of them still do believe in other options, like your traditional medicine, or like the faith-based, where they go and get some water to drink, or they are prayed for and the pastor will tell you, are healed, don't take the ARVs. People will come and collect. Immediately after some months, they disappear. They are no longer, they are lost to follow up. And when you trace, they say, now I'm healed, my pastor is this and that. So we still have those challenges, and hence we're sitting at 77%. Others, they just choose not to at all to even start. And also there with the 77%, we have a bit of a high loss to follow up because there is, as I said, there is always an influx of people that come to eThekwini. Others will cross the borders of their own provinces and come to eThekwini, get help. When they feel they are okay, they cross the border again, go back to where they belong, sometimes without even saying, now, can you transfer me out? They self-transfer themselves back to where they are. You will look all over and there will be nowhere to be found. In terms of viral load monitoring, we took a sample for the viral load done at 12 months, was sitting at 85%. And when the fast track cities started and we did our baseline, we were very low, somewhere around 60%. So we put in intervention to say we need to improve in monitoring the viral loads, and then we've improved greatly. We're sitting at 85%, but we still need to work harder to push it to higher levels. In terms of the viral load suppression, which is the third 90, we are sitting at 93% of the people that are on ARV who are virally suppressed, but we are also worried about the rest that are not suppressing, because we know by now that our people, they go around and they are not necessarily engaging in safe sex, so they would be spreading maybe even resistant viruses. What are we doing then to actually try and push ourselves to reach the 1990s come 2020? In terms of HIV prevention, over and above everything else that we've been doing, now they've introduced the pre-exposure prophylaxis, which is targeting adolescent girls and young women, but is not only limited to them. Anybody that comes and wants to have PrEP is being offered, but the target is the adolescent and young women, as we have indicated that they are the ones that are at most risk and are highly affected by the HIV. So this started as a pilot, few facilities, but now it's becoming policy in South Africa, and we are spreading it, or we are escalating it to other facilities with the help of our donor-funded partners who are actually leading and supporting us to do that. And also for the adolescent and young women from the DREAMS project, we have what we call She Conquers, which is a program that is aiming at building resilience for young girls and adolescent women, for adolescent girls and young women, and empowering them. And it's layering of many prevention interventions where we are trying to ensure that those that are negative, they remain negative. When they begin to engage in sex, they engage in safer sex because they've been empowered and they can be able to make their own decisions. Adolescent and youth-friendly services, that is mainly provided in the facilities where they provide a safe and enhancing environment for young people to come and seek all health services that they might need, including SRH. But we have seen over the years that we are not winning. And now we have a cadre called Youth Ambassadors. The Youth Ambassadors, they go into the communities door to door, looking for the young people and ensuring that they capacitate them, they give them information, and they try and influence them to go to the facilities to get all the services they can get. Male medical circumcision started way back in 2010 and we're still scaling it up. And with mother-to-child transmission, we have made a lot of progress. From 2014, we're sitting at around 20%. Now, with all the improvements in the ART, we are sitting at 0.75% mother-to-child transmission of HIV. HIV testing services, we're targeting high-risk groups. We are not weakening because, you know, when you get to key populations, your sex workers, your MSMs, they are not easy to reach. Trust issues, but we do have organizations that are working specifically with those groups, and we are hoping that beyond them we will be able to sustain those services, but also to increase the number of people that are at high risk. We are targeting the contacts of index HIV positive clients to go and test, and we do that through door-to-door by use of the outreach, ward-based outreach teams, where there's a team of multiple health workers led by the professional nurse, the lay counselors, and all the cadres that work in the community to go door to door looking for the index clients. Extended hours, we are trying to reach men. Men are so difficult to bring to the health services. We are now opening extended hours, maybe very early in the morning, 6:30, and others, they finish very early in the afternoon, about 6 o'clock, because, and also work over weekends, because we're trying to say, wow, what do to ensure that men also are tested for them. And outreach teams, also health screening, which is Hlola Manje Zivikele campaign. This was launched by our President Ramaphosa, which is saying, test and protect your life. It's not only confined to TB and HIV screening, but also screening for non-communicable diseases, your hypertension as well as diabetes, because that is also on the increase. If we are to achieve the sustainable development goals as well as our own national development plan, we have to ensure that we screen also for all those conditions. Treatment and retention in care, active linkage to care, where we offer same-day service, be it at the facility or outreach. We offer treatment buddy support, where a patient is linked to someone in the facility who will take the number and will keep reminding them even to come back for the appointments, SMS reminders, and active tracing of the people that are defaulting. As I've indicated earlier, we have the Welcome Back campaign, where we're saying, let's not ask questions that will push them away again. Let's welcome them back into the system and continue. Decanting our stable clients to collect from external pickup points, which are pharmacies, as well as community chronic clubs, and they go on their own and put a code and take the treatment and go. So all this is efforts to ensure that people, they find it convenient to go and get services. And we're closely monitoring our performance now that 2020 is 2 months, whatever, away from us. So we're monitoring using all those platforms, daily reporting, weekly nerve centers, quarterly reviews, as well as monitoring the performance for counselors, facilities, and outreach. Thank you.